Hey, welcome to the podcast.
Yeah, it's great to be back.
Yes. Yeah, today is the first in a two-part series, our conversation with Jamie Hibbert, who's an Advanced Care Paramedic for the Queensland Ambulance Service. Jamie's been on road for 13 years and more recently operating with an extended scope as a local area assessment and referral unit officer. I needed to read that. Let's just say LARU officer as it's known in the service. So in part one of the interview, Jamie explains the role of LARU in reducing the burden on the hospital system, as well as the rewards and challenges of working as a specialist single officer for LARU. Perhaps most notably, one of the challenges is no lights and sirens. You have to stop at red lights and obey the road rules.
Wow, well, Jamie wasn't always going to be a paramedic, and he tells the story of his career journey from missing out on his first few degree preferences coming out of school to going on to complete an international business degree, and then to a defining moment years later where he realised he wasn't at all happy, and he decided that he was going to become a paramedic and fulfil his passion to really help people.
Yeah, and Jamie's perspective on addressing mental health cases and putting yourself in the shoes of the patient is both inspiring and helpful for anyone wanting to be a better healthcare provider. This episode will be particularly insightful for those interested in learning more about the different scopes of practice within the state service and the different sort of roles and skills required.
Yeah, then in part two, we'll delve into being a paramedic as a father of four as well and hear more about Jamie's published writing on the positive impacts of dark humour amongst paramedics, coping with illness and trauma on a daily basis. And that's coming shortly, but for now, let's get into part one of our interview with Advanced Care Paramedic Jamie Hibbert.
Let's do it.
Another one that I just quickly was, I was a student, second year or something, and it was one of my first paranoid patients' mental health cases that I'd been to. And it went up there and I was patient care and I was still trying to learn patient interviews, and he said, there's these people out to get me and I'm fearful for my life and I need to go to hospital because I'm really psyching out and I don't want to kill myself. And I said, yep, no worries, let's go, and headed down to the car, and it was dark, it was after sunset, and we get into the car and he said, mate, can we turn the lights down because I don't want people to see me? And I was thinking, this guy is off the charts. I mean, this is straight out of Die Hard or something, and then on the way he was telling his story and I was just sort of listening and trying to sound sincerely interested, trying to work out what parts I'm going to tell it, hand over, because half this doesn't really matter to the case. And he looked at me in the eye and it's part of his rambling. He said, look, I know this is all BS to you, but it's real to me. And the way he said it, he just stopped me in my tracks and I went, wow, it's real to him. Now, none of this stuff that was going on that he was talking about, I believe, was actually happening in real life. I believe he was probably under the influence of drugs, paranoid, all that kind of stuff. And it was just coming out, it was manifesting. But the way he said, it's real to him, it just really taught me to listen to the patients and their complaints, because
Great. Well, Jamie, thanks so much for your time today, jumping on the podcast. We can't wait to get into things.
Thanks for having me, guys.
Our pleasure. Now, we're going to go into your role as an advanced care paramedic. You've been on road for 13 years. The last 2 years, you've been working under an extended scope as a LARU officer. We're going to go into what it is. But firstly, mate, you weren't always going to be a paramedic. We met at university 20 years ago. That sounds like way too long. You didn't particularly love your degree, I remember.
No.
There was also a car that you bought, and I haven't told you that I remember this, but it was covered in flower stickers.
Yes.
And for whatever reason, because you were giving me a lift home from Sunshine Coast to Caboolture, and for whatever reason, we were peeling, spent half the day peeling those flower stickers off your car. Do you remember that?
I do. I bought that car as a downgrade because my other one was chewing too much fuel for a student, a uni student, and I bought this thing the night before, and I just literally drove it up because I sold another one that night, and it was I bought it from a lady, and she had the stickers on it, and I hated it. I thought the first thing I'm doing is taking them off. So I was in the car park with some kind of blade or something, peeling these stickers off to make it a more masculine look, being a blue Barina, and I got a lot of fun memories of that car. It's a good one. Thanks for bringing that up.
Now, give us tell us about your journey from there to now being an advanced care paramedic with the Queensland Ambulance Service. Can you elaborate?
So what happened was I had applied to do 4 different degrees. So I always wanted to go into medicine, but never felt myself good enough. So I thought I discovered language that I loved doing, and I applied to do linguistics so I could do translation work, and I was full on going to do that. And my advisor said, put 4 preferences down just in case. And lo and behold, I was offered my last preference, being international business, and I was gutted. I almost didn't start, but someone said, look, you can always jump across and do that. So I thought, well, I'll start. And it was a miserable year, actually. I did not enjoy it. I thought I'll keep going, and I came out the other side with my degree. But the study process itself, I remember thinking the whole time, I'm not a business person. I have no interest in business like that. And it's something that I would try to switch across. Long story short, I didn't. I finished the degree. I thought, oh, well, I'll just try to use this thing. I sort of tried to reprogram my mind. And I got a job in a call center of all things, just taking calls for concrete, ordering concrete trucks and abuse for late orders. And I remember thinking to myself, this is not what I wanted. I felt like I was stuck in a rut, And my supervisor in the job pulled me aside one day and said, you hate this job, don't you? I said, yes. And she says, well, why don't you leave? And I said, I've been trying to leave for a year because I had actually been trying to get other jobs and unsuccessful. It was a bad time to get a job. And she says, well, what do you like to do? I says, I don't know. I like helping people, community stuff, because my resume was filled with things that I loved to do on the side for fun. And I had to stop those things to go to work so I could earn a living. So I thought, she said, well, what about this? What about that? What about police? What about AMBOs? What about, and listed a few other things. And the word AMBO just hit me in the eyes. I thought, I've never thought of that. And because my favorite 2 things to do in life are driving and helping people. And this job would entail both. I thought, and I can get paid for it. So I thought, well, why not? Give it a shot. So I applied, and it took me 18 months to get in. But as soon as I put that application in, this thing rose up inside of me. I thought, wow, I just can't wait to do this. And I still didn't know what it was about. I knew it was like, lights and sirens and hospitals and car accidents and the usual stuff. But something drew me to the aspect of helping other people and then getting a paycheck at the end for having fun, pretty much. And so that was my introduction to ambulance work, pretty much. I always say I kind of fell into it because I never went out going to say I'm going to become a paramedic. And the ultimate irony is something I never told you, Ben, was in the first year of uni, they had the careers expo and all these little stalls lined up and, do this, do that, do, engineering and all that. And there was a little ambulance stall there. And a person standing there with a table and brochures and, stretcher. And I looked at it and I remember thinking, that's not a degree, that's only a diploma. And I walked past because I was out for a degree, because back then it was diploma studies only. And I remember thinking, looking back, 7 or 8 years of my life I had to traverse in order to end up what I was going to do anyway. Because I remember looking at it thinking, oh, that'd be cool. But I was held up by the academic side of not a degree. Of course, it's changed now. But I remember I always laughed thinking, oh, I should have done it then. I'd be so much further ahead in my career. But we go through these seasons of life to teach us things, I think. And I learned a lot in that years before I started. That taught me life skills that actually help me in the job now.
And Jamie, there's, as you alluded to, there's a different setup now. Obviously, you need to go through a bachelor degree to then be registered. There's a couple of different pathways there, but you started a diploma and got more initial on-road experience. Can you talk about the differences of your pathway into the paramedic role as opposed to what it is now?
Yeah, so the biggest factor, I guess, is experience that you don't gain while studying a degree. Mine was a full-time permanent employment straight up out of the gate. So I started off as a student, paramedic student with no scope, no skills, and I was training under a mentor. And I was doing the studies on the side, like the assignments and assessments and stuff. And by the time I qualified 2.5 years later, I had 2.5 full years of full-time on-road experience, which I think has been a lifesaver, no pun intended. But it's been so helpful by the time I was teaching my own students, I had 2.5 years on road. These days, it's degree-based, and I don't know, I think it's up to maybe 6 weeks placements total sometimes for some degrees. Unis are different. But so there's some people coming out with their epaulets on, and they're starting off as a qualified, and they've got maybe a month or two tops of training on road, touching patients and getting that on road, that feel, seeing conditions in real life as opposed to a textbook thing. And so I find some of them are overwhelmed with the reality of ambulance work and dealing with patients, the mental health, the stresses of the job, the getting thrown into high acuity cases without doing more than an assignment on it. So I find a lot of people find themselves, a bit stressed occasionally if they're not the right person for the job or not much life experience behind them. So it's a real combination package that I think people are missing out on these days. I was 27 when I started, and so I hadn't had a massive life experience, but that extra 8 or 9 years compared to when you start sometimes is everything. It's a huge head start, I guess. So yeah, I came out with an academic diploma, and I've since done other studies and upgraded that. But the degree gives you a broader base of learning, especially with the evolution of education. The things that were standard back then when I started are now base level and sort of below even. And there's been new skills, new drugs, new concepts that have been added over the years. And now we are in 2020 with the current scope of practice and academic requirements just to start. So it's been quite an evolution, I think.
Wow. Well, Jamie, it's really good to meet you. Ben was telling me a lot about you before we got the opportunity to jump on this chat with you. And I was just thinking then about that defining moment, I guess, that you had when you were confronted and realized, am I doing really what I want to do? And to see the perseverance, like you said, it was like you were traversing across. I just had that picture of, when you go skiing or snowboarding and you kind of have to go across to get to that point where you go down. And 13 years on now, on-road experience with the Queensland Ambulance Service. And you're now an advanced, what they call an advanced care paramedic. And for someone like me, I just hear the word paramedic and I think, well, that's there's only one kind of paramedic out there, and that's you're in the ambulance. Can you kind of, for our audience today, kind of explain more what is specifically an advanced care paramedic? And I understand you are a LARU officer. A bit more about what that is and maybe where it fits into all the different kinds of, you're alluding to different different kind of broaden your scopes, different areas that you can work in that. It'd be really good to hear some of that.
Okay. So the term advanced care paramedic is, I suppose, I would define it as the industry standard for healthcare pre-hospital. So if you were to go from a scale of 1 to 10 with skill set and scope of practice, advanced care is actually only about 5 or 6 out of 10 for possible scope levels. And I put it there because LARU is an extended scope of practice, so a few extra drugs and skills and stuff. But then you got the critical care paramedic, which is higher again, and they do even more advanced airways and procedures. But then above then you got the high acuity, which is the or they give bloods and do rapid sequence induction and things like that for patients who are literally on the brink of death. And then you got the flight paramedics who do all of that and have the doctors on board, and they do infusions and long flight transports and go pick them up from the car wrecks out at Warwick and all that and bring them straight into the Royal. So when you consider all those higher levels, advanced care paramedic, I'm actually level 2. So the standard is level 2. 20 years ago, you were just a paramedic, and then they introduced advanced care. And then the standard paramedic, you probably hear the word Charlie officer, because Charlie, you got Alpha, Bravo, Charlie. Alpha is the critical care, Bravo is the standard advanced care, Charlie is the lower level that used to be standard that haven't upgraded. Then they introduced level 2 advanced care, which is so refining of certain pain reliefs or other things like cannulation they've increased. So I trained always into advanced care, and then level 2, everyone leveled up. But then anything beyond that is a special training program to progress into other areas. So any time you're met with a crew on road, the odds are you'll be at least have one advanced care level 2 paramedic, but we just call them advanced care paramedics. And then there's almost always a second officer of the same level, but most cases now you've got graduate paramedics who have come out through the degree, and we call them GPIPs, which stands for Graduate Paramedic Induction Program. It's a 1-year full-time on-road where they consolidate their learning in a full-time capacity to get that 1 year's experience and just to consolidate. And after that, they do a final assessment to qualify as an independent practitioner of the scope of practice, and then they are ACP level 2. Most people from there go to, if there's no opportunities for permanent employment, they go into a casual pool where you're a casual officer and work on demand. And but whenever you called in to shift, you are an independent clinician able to work as a single officer, unsupervised, or even have a student. And so that's the sort of the range of the scope. I hope I explained that. So anyone below that, ACP is like a patient transport officer or a Charlie officer, 1 stripe as opposed to 2 stripes, or just someone who's like a first responder, or maybe even in comms with a first aid certificate.
Yeah, thanks for that. That's for a novice like me, that's certainly opened my eyes, for sure.
Yeah, so now for the last 2 years, you've been in the local area assessment referral unit. Used to be called the low acuity assessment unit or something you referred to the other day. But can you explain what that role is? And then I want to hear, because you've been in our discussions, you've really found, it seems like you've kind of found your place, a real role where you feel like utilises all your strengths interpersonally, particularly.
Yep.
And I didn't know this kind of unit. I saw the 4-drive ambulances driving around, but I didn't know the difference between them and, the full white bus, So can you explain what your role is?
Okay, so the LARU officer, low acuity or local area referral unit, it's a single officer role, and it's tailor-made for those who have got a bit more, say 5 years plus experience in the role. And it's aimed at going out and assessing patients and treating them who sort of fall into the low acuity category of work. So you won't be sent to any heart attacks or chest pains or births or car crashes unless you happen to be the absolute closest for miles. And it's a critical issue that needs to be addressed, because a LARU officer is one level up from the ACP level 2. So I've put them going back to that scale. I put them at a 7 out of 10 as opposed to 5 or 6, because they're trained in extra things like I can do stitches and glue for lacerations. That's meet criteria. We can use lignocaine to help numb the site and do other things when giving certain drugs to relieve pain, to reduce the pain of administration. So it's a slightly extended role, but one of the key facets of this particular role is that the LARU was created to help relieve the burden of patient demand on the health system of the hospitals. So I am qualified to assess patients and then leave them at home if they are deemed suitable. I'm also trained in wound management, so I can look at a wound and decide if it's healing okay on its own or it needs dressing, or skin tears. I can fix a skin tear and then decide if it needs to stay at home or could stay at home or needs to be transported. And even then, if I transport, we have the extra sort of ability to go, okay, you don't need a hospital. You need a clinician. You can go to a hub, like a health hub for this, or maybe we can get you back in with your GP. So it doesn't have to be a hospital. The hospital is the best, highest level of care, but in most cases, a doctor's clinic can do the same thing that will be required that the hospital will do anyway, like intravenous antibiotics for some clinics, basic trauma for a laceration that if it's outside of my scope of practice, like I can't do joints or certain areas of the body that are considered high risk. But these local low trauma clinics can do that, just like the hospital can. And sometimes we can leave them at home, give them advice, and say, look, try this, and if that doesn't help, then call us back. And it's not frowned upon, but it's got to be done with a certain level of clinical nous, because a lot of things can be missed. One of the classic conditions that we go to, or should I say categories, not specific condition, is you go to patients who are actually chronically ill, and they're dealing with long-term illness that cannot and won't be cured. So it's more managing the condition rather than fixing it on the spot or taking it to a place for a quick fix. Because these patients, some of them are dying slowly, yes, and some are just managing a chronic illness until such time that it may not kill them, but they'll die with it. And so these patients have a higher possibility of getting septic, or getting conditions that a sub-condition that it can often be missed, or it could be a new onset of a new condition that gets drowned out by their presenting chronic illness. And so we've got extra assessments, so we can do like a focused cardiac assessment, focused abdominal assessment, or a respiratory assessment, or a musculoskeletal or a neurological assessment, like check the cranial nerves, and sometimes isolate a problem that may not have been found. We've actually wrote an article for our local Insight magazine that's internal for QAS, and it was basically showcasing the LARU clinical scope, because I went to this mystery patient who had something wrong and he couldn't tell me what. And I basically went through each assessment in step, and I found nothing. And he needed a transport crew, and I spent 40 minutes waiting for this crew. And the last thing I did was one final assessment in my arsenal of training, and I found what it was that this guy had that was new, and it matched all his presentation. Now, I didn't know exactly what it was, but I said, look, he needs to go to hospital for that. I found something that's not right. Because any other crew would have gone, I don't know, we'll just take you to hospital for something. They wouldn't have maybe found it because they don't go through the training of this particular focused assessment that we can do. So LARU has a few areas of benefit, I guess, where it keeps people out of hospital where they don't need to be there. Got a few extra skills so we can do treatment at home and then leave them at home if it's deemed appropriate. And the other thing is to find sometimes the more hidden problems of people that experiencing that may not be found by standard you call, we haul mentality type. So that's probably LARU in a nutshell. We don't have a stretcher. It's just single officer, no partner, gear, and seat in the back of the car or the front. and we don't have lights or sirens either. So I miss Daisy everywhere. Just drive along. If they send me to a high acuity job, I've been to many cardiac arrests, first on scene, closest by 20 minutes. I have to go road speed, stop at the red lights, wait to turn right. It's painful sometimes, but if I get a speeding fine, there's no justification for it because I don't have the vehicle to do lights and sirens in a high acuity situation.
Wow, that's interesting.
Sorry?
That's really interesting. I didn't know that.
Yeah, so if you see the SUVs getting around with lights and sirens, they're actually the critical care paramedic. And then we drive Hyundai iLoads at the moment. I call them Pi vans because they look exactly like a Pi van. But they don't have lights or sirens, just little orange flicker lights. And it's a mindset. LARU is a different game altogether. You're trained you start on a truck, you go through all the other stuff, and then you switch to a different mindset of game. You still got to deal with your patients. And I forgot to answer your question, Tim, about dealing with people. I find that the best part about my role, from a personal or interpersonal side, is giving the patient that one-on-one experience, that tailor-made response to their needs. And I think anyone needs to do this, even if they're with a partner. But with LARU, they give you extra time on scene to just focus in on what the bigger picture is, not just a presenting issue. And with that, I like to use even my sense of humour to make light, not make light of the situation, but to help the patient feel more comfortable about what's going on, and to really disarm their fears and worries about stuff. Because I've been to patients where they're just really worked up, and it's really nothing, but they don't know that. So patient education is huge. Letting them know, A, that what they're experiencing is normal, but B, that it's not an emergency that doesn't need, a hospital now, but it needs treatment, or it needs something. Or actually even the other way where they call for, it's just nothing, and you find a bunch of vital signs that are totally out of whack. And I go, mate, you should have called 2 days ago. Oh, I didn't want to waste your time. It's like, dude, you're not wasting my time. Let's go now.
Yeah.
So that's a long, I suppose.
No,
but yeah.
Look, I feel like my mind is like being open to, just not only this specific role, but the many different avenues that people that really want to serve, are signing up to maybe become a paramedic can actually serve in.
Yep.
I mean, you're a remarkable person, Jamie. I love the I guess the real passion you have to really care for that patient, and I can really see that you're definitely well suited for that role. And I think we find that with a lot of folk that we're interviewing, that the dedication that it takes to not only just do a job, but to actually do it well and thoroughly.
Yeah.
I don't think is something that people coming into these studies actually realise. It actually takes that element of quality and care. Yeah,
maybe slight diversion, but a lot of the complaints we get are attitudinal from officers or from patients about crews. People they're in love with ambulance work. Like they come to scene, yes, we're heroes, we're whatever. Like, oh, I'm so glad you're here. But when things go sour at 3 a.m, when a crew doesn't want to be there, everyone complains about the bad attitude of the crews.
Wow.
I was actually a subject of a complaint. I was the driver of a crew one night when we rocked up 3 a.m, and my partner, who was patient care, did all the talking. And I felt uneasy with the way it was going, but I didn't say anything because I was just the driver. Not that that's anything less, because I'm still qualified, but I let it happen. Next week, complaint come out about us, and I still remember it said the crew made me feel stupid for calling an ambulance. And I remember thinking, I didn't even say a word. How dare they? But then I had a check in my heart. I thought, well, wait a minute. I allowed that to happen. I was there, and I didn't say anything. I didn't defend the patient. I didn't actually correct my partner, and I was just as responsible. So my attitude, even though it was silent, was allowed to be reflected through my partner's words and his tone of voice and body language. And I was responsible for that. So, yeah, it's all about, a lot of it is attitude. You know, your training is superb. You get all you need, even with uni and limited experience, you get awesome training. But no one can change your attitude but you. You know, and how you respond to your patients, how you treat your patients, how you downplay or upscale the problem is totally up to the individual.
I guess it's that real difference, isn't it, between doing a job, because you've got to do a job, you got to pay the bills,
right?
And I'll do it to the level I can, but it then moves into, as opposed to fulfilling a sense of purpose.
And I'll be honest, it can be difficult because I'm sure you've got things going on in your personal life, and not everyone wakes up, no matter how much you like your job and things are going well, you kind of do have to switch on. You're kind of dealing with potential, you know, life, death, you know, could be very serious situations, and you kind of need to make sure you're able to do that. How do you manage that?
I suppose the word compartmentalization comes to mind. Like one of the biggest memories I've had is, you know, you go to this massive resus, a huge, like, traumatic case. There's grief, there's death, it's catastrophic, and then you got to go from that. You know, you've had the biggest job of your career. Sometimes you have a debrief, whatever, and then sometime later you go to the next job, and it's a headache, and the patient goes, "I've been waiting for you for 4 hours. Where have you been?" You know, and you just replay the last 4 hours of your life, and you look at that patient. You're almost looking through them, thinking, "You have no idea what I've just been through, and you're complaining about a headache." You know, like, I've just left a mum holding her dead baby who died from SIDS or drowned in a pool, or, you know, and we've cut clothing off and put needles in, and, you know, all that. And now you're complaining about a headache. But that person is still going through a big event for them. And so sometimes we're human, we fail miserably sometimes, and that's probably some of the other complaint generation. But it's about, okay, I've just got to put all that behind me now and deal with this patient as if for the first time, because it is the first time for them sometimes. But even if they're a frequent flyer, it's the first time you've dealt with them for that case, for that day. And that's incredibly difficult to do. Sometimes it takes years to practice, and occasionally to put people off road because they can't handle the dynamics of going from an absolute code 1, category 1 patient to this patient doesn't even need to the waiting room type of job. And differentiating that or separating them in your mind from each other is difficult. It takes practice, but something that I've tried to take into, especially for the LARU, because you go from lights and sirens, half the jobs, to never lights and sirens, and they're all just, you know, not in, I don't want to say not important. They're not high acuity. And I had to develop the mindset that every patient needs me for this case. This person that I'm going to, some of the most ridiculous circumstances I've been pulled out of to go to, I feel that we're like, "Oh, you've got to be kidding me." And I go there, I'm cranky, I'm like, "Oh, this is stupid." And then I'll get there, I'll meet the patient, I'll see their case, I'll treat them, I'll find their vital signs, and I go, "I am so glad I met you for this job, for this case. I could make that difference that no other crew would have made." I remember I've had a very difficult patient one day. She was very needy. She had a genuine case that needed treatment. Now, wasn't life-threatening. It was just there. And one of the nightmares of the job is getting ramped at hospital. I hate getting ramped. I find it demoralizing being stuck in a corridor for 2 to 3 hours with a patient on a stretcher. I'd rather drive to Gold Coast and back on one job than sit in a corridor for 3 hours. That's just me. People love it because it's downtime for them. But I remember this patient, she was was hurting. She was in pain. I'd maxed out my pain relief. She was stuck at hospital. She needed to lie down. She needed to sit up. It hurt. She needed to go to the toilet. She needed her bag. It was painful. And then I was 3 hours doing this with her, and it gets emotionally draining. You know, it wasn't a traumatic job at all, but I remember thinking to myself, I cannot wait to get away from this person and just flee, you know? And I was getting really within myself, just like, I'm done. Going home or something. And then right at the end, we get our bed number and we go to the corridor, up the corridor to the cubicle. And then we've got the process of getting her painfully onto the bed because she's delicate and hurting. And finally I do the handover and like, I'm out of here. And just as I turn to leave, she grabs me by the hand and looks me in the eyes and says, "Thank you." And just like the emotion just that flooded from her to me, it was like, I knew exactly what she meant. Like, thank you for everything you have just done. And suddenly all of that 3 hours was worth it. And I remember feeling a twinge of selfishness, but thinking like, you shouldn't have been so selfish, you know? She was in pain and all that, but it was just, for me, it was a defining moment where I went, wow, I didn't think any of that mattered, but it all mattered to her.
Wow.
And it was, I suppose it led into development of that mentality down the track. Another one that I'll just quickly was, I was a student for second year or something, and it was one of my first paranoid patients' mental health cases that I'd been to. And it went up there and I was patient care and I was still trying to learn patient interviews. And he said, you know, there's people out to get me and I'm just fearful for my life and I need to go to hospital because I'm really psyching out and I don't want to kill myself. And I said, yep, no worries, let's go. And headed down to the car and it was dark. It was after sunset. And we get into the car and he said, mate, can we turn the lights down because I don't want people to see me? And I was thinking, this guy is off the charts. I mean, this is straight out of Die Hard or something, you know. And then on the way he was telling his story and I was just sort of listening and trying to sound sincerely interested, you know, trying to work out what parts I'm going to tell it, hand over, because half this doesn't really matter to the case. And he looked at me in the eye and it's part of his rambling. He said, look, I know this is all BS to you, but it's real to me. And the way he said it, he just stopped me in my tracks and I went, wow, it's real to him. Now, none of this stuff that was going on that he was talking about, I believe, was actually happening in real life. I believe he was probably under the influence of drugs, paranoid, all that kind of stuff. And it was just coming out. It was manifesting. But the way he said, it's real to him, it just really taught me to listen to the patient and their complaints, because it's not quite the customer's always right, like a shopping experience, because often they're wrong. They're just misinformed, uneducated. They don't know what's going on. But at the moment of pain that they're experiencing, the moment they can't breathe, when their SpO2 is 99%, they can't breathe. And that you just treat them like that. It's not like, oh, it's still fine, your SATs are good, or, oh, look, I've given you 10 of morphine, you should be broken by now. If it hurts for them, it hurts. If they can't breathe, they can't breathe. And just it's the subjectivity of patient care that people, I think, ignore, because we go on the objective numbers. This fracture has been splintered and it's now straight. I've given you lots of pain relief. You've got oxygen. You know, you're sitting upright. There's no way you can't breathe. And we deal objectively, I think, a bit too much when the patient is subjective and they're going, I can't breathe, it hurts, I'm scared, and I'm hungry. And so that's the angle that they deal with us, and we try to hit it with the objective, and the two do not meet sometimes. And that's where we need to change our mindset and go, okay, let's treat the patient from their point of view, their angle, their perspective, and try that again. And once that happens, it's a whole different experience, because they feel that you're actually on their side now, you know. And there's hundreds of stories like that, but wow. I suppose they're maybe the key principles of all of them that keep coming home.
So I'm hearing this, you know, that simple way of putting yourself in the person's shoes is such a a key kind of perspective when you're going in and helping somebody not non-judgmental and trying to put yourself in the place of them. Yeah.
Paramedics are the worst judges in the world, I've got to say. You read the little, it's called the MDT, the mobile data terminal, the screen that gives you the case details. You read that and you have assessed, treated, judged, diagnosed, and discharged them before you even get to scene. Because you read and go, this is stupid, And my other rule is the MDT is always wrong, because I'll give you details, but it only provides a skeletal framework of what you're going to. And half the time it's not even true or accurate at all. The only thing correct is the address, and even they're sketchy sometimes because they change. Because and once again, it's stuff you pick up from crews as you're learning, as you're training. You've got to guard yourself against picking up bad judgmental habits